My name is Eric Crowley. I'm a clinical athletic trainer at Mayo Clinic Sports Medicine and the concussion specialist.
My name is David Soma, and I'm a pediatrician and sports medicine doctor at the Mayo Clinic and help to lead our concussion program as well. Eric, concussions can happen, in all different settings, and many of our providers and people that care for those with concussions can have it happen both on the sidelines as well as in the clinic. So would you be willing to talk about, as an athletic trainer, kind of what you do when you're making that assessment on the sidelines or at the time of the injury?
Exactly, yeah. When we're on a field, we just have to be cognizant of what's going on with the game and watching for those contacts, for that blow to the head, the helmet-to-helmet contact, the head to the ground. So whether it's a football game, a hockey game, you're watching the field to see if there's anything that happens on the field. And then if you see that, then play stops and you can go out and assess. So things that you're looking for, when the athlete sustains that head-to-head trauma or head-to-head contact, you're looking to see if they shake their head's down, what is their reaction after the hit? Do they get up right away, or if they're down on the field? So if they are down on the field, going out to the field, and you're looking at different red flags. So you want to see, are they vomiting? Do they have a loss of consciousness? Do they have any cervical spine tenderness? Does their mood or affect change? Do they get combative? So you're looking at those things when you're out on the field. You can go through specific assessments, the MADIX assessment, which looks at specific questions that you know the answer to. So for instance, what venue are we at? Who are you playing? Who scored last? So you want to know the questions to your answers, not what did they have for supper the other day, which you don't know the questions for. Or looking at the Glasgow-Coma scale, and that's really assessment of vision and verbal assessment and motor assessment too. So looking at those things and determining, do they need to go to the emergency room, or can we continue to assess them and do a further assessment on the sideline, or take them into a quieter environment and look at them more on a one-on-one.
So you're really trying to target kind of when that person gets injured. Do they have an injury that's more concerning, a neck injury, intracranial hemorrhage, skull fracture, something like that would make you need to say calling in an ambulance or sending them to the ER, versus is this something that's more straightforward, like a concussion, and then making that decision of should they return to the game or not? And obviously, if that person you think has a concussion, you're going to take them out, correct?
Exactly. You're looking at those same thing, yeah, like you said, spine injury, cranial bleed, those sort of things that pop up, which they would require to go to the emergency room right away, or emergency transport. Perfect. So can you tell us a little bit about what you would do in the office or on the sideline after you determine that it's not an extensive injury that's more of a standard sport-related concussion?
Yeah, fortunately, most of the time by they come into the clinic, they've already had several hours, even sometimes days since the injury, and the fact that they've had that many time between the injury and when you see them really bodes well for the athlete. That means that the likelihood of them having a severe neck or head injury is quite a bit lower. And in all honesty, the people that were at the sidelines doing the initial assessment or in the ER have done a lot of the hard work for us, because they probably have ruled out that more concerning injury, and now we can really focus in on what the concussion is. One of the tools that we can use is the Sport Concussion Assessment Tool number 5. There is a child version as well that can be used, and in that version it kind of just makes things a little bit simpler for that younger population. But this is a tool that kind of guides you through various aspects, many of the things that Eric has already talked about, which can be done on the sidelines, but then guides you into the clinic. And in the clinic, one of the things that you always want to start off with is gathering all that information that Eric talked about. We want to be able to know, did they lose consciousness? Did they have memory loss? What was the mechanism of the injury? Those types of information sometimes can provide a little bit of value trying to anticipate how this patient will do with their recovery. In addition to that, you want to kind of assess how did they feel afterwards? How are their symptoms at the time of the injury? What were they experiencing? Because sometimes those are the symptoms that can linger, or they sometimes can evolve over time. I find it really important to try to understand kind of what is their past medical history. People with a history of depression, anxiety, learning disorders, ADHD, history of migraines, a lot of the symptoms of those conditions do overlap with those symptoms of a concussion. So I do think it's really important. And again, having a relationship with the athlete, which oftentimes the athletic trainer does, to know kind of what they do is really helpful. So having that relay of information between primary care and the team is really valuable. And then having that information can help project prognosis. We know that people with underlying conditions have a little bit more potential for prolonged recovery from some of these concussions, which is really important. We also kind of want to assess the symptom severity. We know that people that have really severe symptoms or symptoms that are scored out much higher can be problematic. In that SCAT-5 tool, they list out 22 common symptoms of concussion, and you can score them from 0 to 6. And depending upon kind of what that score is, it can help you to kind of understand their degree of impairment that they might be experiencing. And that can help guide decisions moving forward.
Yeah, one thing that I like what we do is we try to do a baseline assessment with a lot of our athletes. We have a database where we ask them ahead of time, have they had any previous concussions? Do they have a history of ADD, ADHD, depression, anxiety? So we're asking those things ahead of time along with those same symptoms that you went over. And that kind of helps us give an idea of their actual baseline, and then once they've had that concussion, where we think they're going to be progressing to and when we feel like they're back to normal. So that'll be one of our assessments that we utilize.
Yeah, I think that's so important. Understanding that athlete before the injury occurs and kind of what they're dealing with is really helpful, because again, if someone at baseline has fatigue or difficulty concentrating or headaches, that can really aid in kind of helping understand what they're like right now. And I think also understanding what is their normal academic performance. How are they as a student? What are their grades? What types of school subjects do they struggle with more than others? Those are all things that are important as you're guiding that athlete back to sports and activity. And then from a physical activity, it's also important to understand what sports were they doing when the injury occurred, but what do they have coming up on the horizon? What are the timing of the upcoming games? What sports are they returning to? Going back to a sport like golf obviously poses different risks than going back into a contact collision sport like football or hockey or soccer or something like that. So it's a little bit of a different story.
So we see the athletes will get their history, their background information, and then we will do our typical assessment. And then after our assessment, we're looking at their symptoms, their neurocognitive assessment. We use the standardized assessment of concussion, or the SAC tool. And then there you can use online tools as well. You can do those at baseline as well as after injury. And then there's other saccadic eye movement tests that we'll also look at. Once we make that determination that the athletes had a concussion, is there anything that we can look at from getting back to school, or are there accommodations that we can have them work on?
Yeah, absolutely. You bring up a good point. Knowing them before helps to make those decisions. But when you see that athlete and you suspect they have that concussion, it's really important to create or design a plan individual for that person. Not everybody's going to follow the same recipe or the same kind of process as they recover. Some are going to be quicker, some are going to be slower. Some might struggle with certain symptoms, some might struggle with others. So one of the things we talk about is creating a school support plan. Almost all of our kids that we see are student athletes. And so we need to make sure that they have a plan to get back into school. And that could be sometimes shortening the day, sometimes having certain accommodations like less screen time or maybe less light stimulation can be helpful. Sometimes it's even taking more breaks or minimizing the number of tests. A lot of these accommodations I would describe as relative rest, where we are just adjusting things rather than what we consider complete rest. Complete rest is saying go to your room, sit in the dark, don't do anything for a long time. We know that doesn't typically go very well for athletes. Kids are not used to that. They're active individuals. They like a little bit of stimulation. They need to be socialized if possible. So I think a lot of those things are really important to architect that specific plan. And once you get them back into school, then that secondary part of getting them back into activity is really important. And that's where a lot of times we do rely on you guys as athletic trainers to kind of help them back through that physical process. So you want to talk a little bit about how you get somebody back physically to sports?
Yeah. So we know the research does show that it's valuable to get these athletes doing some light physical activity. We want to try to keep it sub-symptom threshold, or where the symptoms aren't being made worse through physical activity. Something such as a stationary bike for 10, 15 minutes and slowly working up in that and monitoring their symptoms while they're doing it. Sometimes we may use a tool like the Buffalo Concussion Treadmill Test, where we can really assess their symptoms as well as their heart rate and monitor them as we really ramp up their heart rate and kind of challenge them physically. But we know that getting these athletes back to light physical activity is imperative and does seem to help them improve with their symptoms going forward.
Yeah, I think that there is more and more research saying that a little bit of that light exercise, even early on in the process, is really, really valuable. And I've seen that in clinic where kids really don't have any ability to exercise. It affects their sleep, it affects kind of their routines and how they're feeling. So I think, again, a little bit of light exercise under the guidance of someone who can kind of monitor those symptoms and kind of determine that they're doing it safely and properly. And tell me a little bit about kind of that sequential return what are some of the tips and tricks that you go through with kids when you're talking through that? When
we initially start, like we talked about, we have various levels, and our first level is that light physical activity. That's at 10 to 15 minutes on a stationary bike, a walk, a light jog, staying sub-symptom threshold, staying below symptoms. And then if we look at moving that patient on after they've done well with that stage, going into level 3, which is more sport-specific activity where we increase the time, we increase the intensity, anywhere from around 30 to 45 minutes. If they tolerate that well, then going on to level 4, which is a non-contact practice. And if they tolerate that well, which is approximately, again, increasing in the time as well as the intensity, and then next would be a full practice, and then after that would be a competition at that level 6 return to play.
Yeah, and I would imagine that sometimes you have to get creative because sports like dance or golf or tennis, how does that become a contact or how do you work them in? And again, I think working with a trainer or somebody at the school to kind of design that plan is really good. Wouldn't you agree?
I agree, yeah. We kind of lay it out for each sport so our athletic trainers can have a protocol to go back to and look at that protocol and utilize that going forward to bring them back to sport healthy.
Yeah, and we, ideally, when the older kids or the high school kids, they have more resources and more availability. But we do care for kids of all ages for concussions, and it's important to understand that they may not have the same resources. So sometimes working with the parent or the coach or someone else to help guide them through that process is really important. In summary, I think that we've discussed a lot today. We've talked about kind of doing that initial history on the sidelines, ruling out concerning stuff, how we evaluate kids in the clinic, looking for their past medical history, how they're feeling, their symptoms. We demonstrated a little bit of that sport concussion assessment tool. We also kind of talked about the physical exam, that neurologic exam, as well as that vestibular ocular motor screen, and then talking a little bit more kind of about balance and other aspects as well. And all those pieces together kind of combine to help us make our decision. There is not one specific test or one specific finding that you can say, if that's abnormal, they absolutely have a concussion. You have to take everything into context and determine if this is the most likely explanation for the person's symptoms. And that'll really help us understand if they have a concussion. And then once you make that diagnosis, giving them those specific guidance on return to school, return to sports, and all those activities are really important. Not all athletes have a baseline test. Some do, and that can be helpful, but not a requirement. We can care for kids regardless of what their status was before the concussion. We can kind of gather that information as we go. And I do think there's a lot of tools out there. There are computerized tools. There's tools that are on iPads or phones. There's ones that assess balance, ones that assess motion. And all those things can be used in combination to help make that clinical decision. So now that we've talked about kind of the sideline assessment, and we've also talked about that clinic evaluation, that's all that history, that gathering of information to help guide the decision. Now it's time to transition and start thinking about what do we need to do from an exam. And I think Eric will demonstrate a lot of this for us. He's going to go through talking about kind of that neurologic examination, that balance assessment, that eye exam components, and all the different aspects of the exam, and we'll walk through that. But it's really important to combine both that history as well as that exam. We will be demonstrating the Sport Concussion Assessment Tool number 5. Included in that is an initial assessment looking for red flags for more concerning findings, observable signs of concussion, a Maddox questionnaire for memory and orientation, assessing the Glasgow Coma Scale, performing a cervical spine exam, gathering relevant background or history, assessing symptoms of the individual, and then proceeding on to do more of an assessment of cognition. Eric will now demonstrate the standardized assessment of concussion, which is a cognitive screen where we will be assessing her function, and the score would be a total of 30. Any test that she isn't able to do would be a 1-point deduction. I would like to introduce Ashley Harding. She has volunteered today to help us with our assessment.
What is the date today?
February 16th,
And the year?
2021,
Day of the week?
Tuesday,
And about what time is it? Within an hour?
10.
Good. 5 words. I'm going to say them, then I want you to say them. Elbow, apple, carpet, saddle, bubble.
Elbow, apple, carpet, saddle, bubble.
Again, elbow, apple, carpet, saddle, bubble.
Elbow, apple, carpet, saddle, bubble.
Again, elbow, apple, carpet, saddle, bubble.
Elbow, apple, carpet, saddle, bubble.
Remember those, we'll be coming back to them. I'm going to say some numbers and I want you to repeat them back to me in reverse order of how I say them. 3, 9, 6.
6, 9, 3.
4, 2, 6, 8.
8, 6, 4, 2, 4.
And we'll continue with the numbers with 5 numbers in reverse order and 6 numbers in reverse order. Next, we'll look at the patient's ability to say the months of the year in reverse order.
December, November, October, September, August, July, June, May, April, March, February, January.
And then as a part of the delayed recall, we would ask her to recite the previous words. Do you remember those words?
Elbow, apple, carpet, saddle, bubble.
So Eric's going to start now by performing a neck exam. That'll include inspection of the neck, looking for any asymmetry, assessing the range of motion in all directions, as well as performing palpation and a Sperling's maneuver, assessing flexion and extension, lateral flexion in each direction, and rotation laterally in each direction, looking for any asymmetry or development of pain. He is now palpating the midline of the cervical spine, assessing for any step-offs or bony tenderness. He will then assess the paraspinal musculature, again looking for any signs of tenderness. He's then going to proceed with a Sperling's maneuver where the neck is extended, laterally flexed and compressed to see if there's any development of any numbness, tingling, or pain. Next, Eric is going to proceed with doing a neurologic exam, starting with the cranial nerves, where he's going to be assessing the eye movements, and also will be assessing pupillary light response, looking to see if there's any deficits. He will then proceed for a pupillary light response, looking to see if each pupil reacts, and there's appropriate accommodation of not only the ipsilateral but the contralateral side, looking for pupillary constriction on the ipsilateral side, and then now doing it again, looking to see if the contralateral eye also. Good. He's now assessing cranial nerve 5, which is looking at the muscles of mastication. As he puts his fingers over the muscle, she clenches her teeth, and you can feel that muscle contract. He will then proceed to doing cranial nerve 7, which is looking at the sensation of the distribution of the face. So she's supposed to be reporting if it feels similar on both sides, as well as closing of the eyes tightly. Good. We will then assess for swallowing as she swallows appropriately, and typically if they can speak, this is an adequate assessment of cranial nerves 9 and 10. We will then proceed to cranial nerve 12, which is looking at the muscles of the tongue, so she can stick out her tongue, move it side to side. Good. Then proceed with assessment of the muscles of the neck for cranial nerve 11. So shrugging the shoulders against resistance. Good. We will then proceed with cerebellar testing, where we can kind of assess by having her touch her nose and then touch Eric's finger and going back and forth rapidly between the nose and the target. This can be done on both sides. The next thing we're going to do is a concussion-specific evaluation called the vestibular ocular motor screen. Eric is going to first assess for what's called smooth pursuit. Smooth pursuit is watching the eyes move across the visual plane both laterally and vertically, going from one side to the other. Should take approximately 2 seconds, and what you're looking for is any interrupted eye movements or development of symptoms. We will then proceed to doing saccades. Saccades is rapid alternating eye movements in the horizontal as well as the vertical. In this situation, the objects should be about 3 feet away from the face and about 1.5 feet in the direction both left and right of midline. Then repeating the exact same thing in the vertical. And you're looking for any abnormal eye movements, over targeting or under targeting, and then development of symptoms afterwards. Next, we're going to proceed with near-point convergence. In this situation, Eric will take and hold an X in a 14-point font away from the nose and bring it closer to her eyes. When she sees double, she will indicate stop, at what point we can measure the distance. That will be done 3 times, and you will take the average of the 3 measurements roughly. Good. Assessing for that abnormal convergence or the development of symptoms. Typical normals should be between 5 and 7 centimeters of a maximal distance. Anything greater than that would be considered an abnormal test. So Eric is now proceeding with the vestibular ocular reflex test. She's moving her head side to side about 30 degrees to each direction, keeping her eye on the target, going 180 beats per minute, looking to see as those eyes appropriately stay fixed on the target. She will do a total of 10 repetitions. At the conclusion of the test, after about 10 seconds, you want to assess for the development of those symptoms of headache, dizziness, nausea, or fogginess. Ashley's going to proceed with the visual motion sensitivity test. Well, she will place 1 or 2 arms directly in front of her face, and she will turn at a rate of about 50 per minute, 1 per second, where she will look at her target and look for any abnormal eye movements, difficulty with balance, or development of symptoms. You will do a total of 10, 5 repetitions each way. So part of a neurologic exam is including a strength assessment. Just for simplicity, we will proceed with just the upper extremity, assessing for basic range of motion, strength, and sensation. She is pushing against the resistance of Eric, assessing the major muscle groups.
Bring your wrists back. Hold. Hold. Wrists down. Hold. Hold. Straight ahead. Tilt them in. Hold. Wrists out. Hold. Fingers out nice and wide. Don't want to push them together. Squeeze my fingers as hard as you can. Relax. Sensation. Does this feel the same as this on both sides?
When assessing sensation, you're looking for the presence of sensation, but also symmetry between the left and the right.
There. 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 Does this feel the same as this both sides? Here. Here.
And similar instructions can be provided for the lower extremity as well. All right, we are now going to proceed with doing one balance assessment of Ashley. There are numerous different types, but this one is specifically called the Modified Balance Error Scoring System, or the MBES. And the purpose of this is to have Ashley assume 3 positions. In each of the positions, she will hold that position as best she can for 20 seconds. And with each of those positions, we will look for signs of errors. Errors would be that her eyes would open, her hands would come off of her hip, she would sway greater than 30 degrees in any direction, or her feet would change position on the floor. The first one will have her feet together, hands on her hips, and her eyes will close, and we will time this for 20 seconds, counting the number of errors that she has. Good? She will then take her dominant leg and lift it up. She will then close her eyes and keep her balance again. That would be considered an error. Another error. Perfect. And again, when assessing the scoring, you are trying to count the number of errors. If they have a baseline, you would compare against their baseline. If they do not, it is normal to have a few errors, but if they are greater than 10 and 20 seconds or they are unable to complete the task, that would be considered a fail. The last position will be with their dominant leg in the front, with her hands on her hips and her eyes closed. The heel should be touching the toe during this test. And stop. Perfect. That is the Modified Balance Error Scoring System. We will now have Ashley walk from heel to toe, front to back, ensuring that her heel touches her toe with every one, and going forward and back, assessing for balance or any other abnormality. As a part of the neurologic exam, we can also assess a test called the pronator drift. She will stand with her feet together. Her hands will be extended in front of her, palms to the sky, and she will close her eyes. We're assessing to see if she's able to maintain her balance and see if her palms drift towards the midline or become pronated. This is a normal test.
Thank you so much. My name is Eric Crowley.
My name is David Soma. Please reach out to us at any point in Mayo Clinic Sports Medicine if you have any questions regarding assessment, evaluation, and treatment of concussions.